So it's my distinct pleasure to welcome you here this morning to our first panel session, The Power of Lived Experience. There could not be a truer title. My name is Maggie Carastucci, and I'm a caregiver for my sister, who has both breast cancer and a rare appendiceal cancer that wasn't diagnosed for more than a year because of the fact that her care was dispensed in a multidisciplinary way rather than integrated in an interdisciplinary way. She was seen at 4 different academic centers where she was a hallway patient, where their various systems couldn't talk to each other, and where we relied on my 5 binders of information, my obsessive drawings, and my flow charts, and where siloed technology was definitely not our friend. I've worked in the health system for decades, and I'm here to tell you this morning that I've learned far more in my few years as a caregiver than I have from any textbook or any theory. I've lived it, and in so doing, I've seen the good, I've seen the bad, and I've seen the ugly. In our situation, had our lived experience, our story, our voices being heard, it would have made a significant difference to her life as a patient and our life as a family. As I reflect on our experience, I'd say that once her diagnosis was made, she received world-class excellent treatment, for which we are all eternally grateful. But here's the thing, she did not receive excellent care. And it's time to change that. And changing that starts by listening. It's conferences like this one that focus on the patient and caregiver voice that give me hope. I just want to start our session today by reminding you that our sole purpose today is to hear the voices of people with lived experience. Every single one of your voices matters. I'm looking forward to our conversation about the importance and power of lived experience. I want to start by thanking each one of our panelists for their willingness to retell their stories. This isn't an easy thing to do. These stories are painful, and it exposes each of us to pain and trauma that we've experienced in our lives. And they're doing it so they can help others and by being part of a transformation of our health system. Telling their stories is hard to do. So I want to shift and introduce our panel. I want to start with you, Claire. So Claire Dawe-McCord has a really full plate. She's a science student at McMaster, and she's pursuing her dream of eventually being a physician one day. She's an active patient partner who has put a tremendous focus of her work onto Children's Hospital of Eastern Ontario, or CHEO as most of us know it. She's a co-chair of the Ontario Pediatric Health Team. Claire also has a rare and complex neuromuscular disorder that was diagnosed in her teens and that continues to impact her life today. The list of Claire's accomplishments goes on, but I won't take any more time. And with that, I'm going to turn it over to you, Claire, to share your story with us.
Thank you very much for having me, Maggie. And thank you very much for that lovely introduction. I think it's really important that we start these conversations with an introduction like that, because I feel like often there's a sense of depersonalization when you tell your patient's story. So thank you. So I grew up as somebody who was relatively healthy. It wasn't until my preteens that I started to have some weird medical symptoms. And at first it seemed that maybe I was just super accident prone. My mom used to joke that I inherited my dad's lack of coordination. But I would always be covered in bruises. I was injured. And as the years went on, I started having more and more episodes where my heart would race and I wouldn't be able to feel my legs. But somehow every single test that I had was inconclusive. So by the time that I turned 16, I honestly thought that maybe I was just going crazy and it was all in my head. And then I ended up in multi-organ failure in an ICU and in a coma. And I was there for 3 months. And once again, every test was inconclusive. My intensive care specialist told my parents at the time, you know, sometimes kids just get better and we never find out what happened to them. And that was until I got a call from my neurologist who had run a genetics panel on me before my admission. And he told me that I had an extremely rare sodium channel malformation. So rare, in fact, that the mutation had never been seen before. And then in the following weeks, I was also diagnosed with a connective tissue disorder called Ehlers-Danlos syndrome, which explained a lot of my symptoms. And the 5 years since then have been, to put it lightly, a roller coaster. I could sit here all day and tell you stories of my various admissions, but I think that there's one story in particular that really demonstrates how a failure in technology and communication almost cost me my life. So on top of the daily pain and stiffness associated with my neuromuscular disorder, it can cause massive electrolyte imbalances. And to put the word massive into perspective, for those of you who aren't in healthcare, the normal range for potassium is about 3.5 to 5 millimoles per liter, with levels under 2.5 or above 6 being considered life-threatening. My potassium has gone as low as 1.9 and as high as 9.2. The night that my potassium went up to 9.2, I have a very distinct memory of being in the ER and having the doctor holding my hand and telling me that he wasn't going to let me die, as he put defibrillator pads on my chest and called a code because my heart couldn't handle the stress anymore. This didn't have to happen. The reason why it got so high before I got help was because I just turned 18. And you would think that turning 18 is a cause for celebration, but for me, turning 18 meant that I could no longer go to the pediatric hospital that knew me. So when I went to go check into the emergency department, obviously very unwell, the only thing they had on my file was an X-ray of my left pinky from when I was 9. They didn't have a single record from the Children's Hospital. They didn't know about my diagnoses. They didn't know that I had the kidney function of a 93-year-old. They didn't know about my surgeries, nothing. So there I was, quite literally dying. And because of a lack of technology, I had to fight the triage nurse to get her to believe that what I was saying was as serious as it was. And then after I waited 4 hours to be seen by a physician, I had to explain my very complicated history while vomiting profusely and clutching my chest because it felt like somebody was crushing my heart. So when I went off to university the year after that, as you can expect, as anyone who's moved a student into university knows, that my car was packed to the rafters. It's honestly a miracle that I didn't crash exiting my driveway. And right at my feet, I had a box about this big. And inside of that box were a bunch of binders. And these weren't just extra school supplies. They were a summary of my medical records that I still take with me everywhere that I go, because we're not yet at a point where I can trust that if I'm in a crisis, my healthcare providers will have the information they need to treat me. And that is why advancements in technology and healthcare are so important to me.
Thank you so much, Claire. You know, I think when I reflect on your story, and I've heard you speak before, but those transitions in care and that lack of integration between those various organizations and sectors just really speaks to me of one of those big gaps that I think we've all experienced and that really needs to be paid attention to. Thank you so much for sharing that. So we're really honored to have Denise Mcquaig with us today. Denise is a Métis elder who lives in BC and who has shared her expertise as an Indigenous advisory on Aboriginal mental health and addictions while supporting the Canadian Foundation for Healthcare Improvement as an Indigenous coach and mentor. I had a chance to chat with Denise about the fact that her family suffered the illness and loss of her father early on in the pandemic. And she has a really important perspective that I want to thank her for sharing with us today. Denise, thank you so much for being here and thank you for being willing to share your story with us.
Thank you, Maggie. So I want to share the story of my father's passing, but I think really we need to go back even a year before that into January of 2019 when he suffered a significant bleed. And we were really prepared for him to leave us on his spirit journey at that time. He took 5 blood transfusions, and at the time that they offered the 6th, he refused. I remember him very clearly say, "I'm old, save the blood for the babies. I'm tired and I'm ready to go. And for reasons that no one can explain, his bleed stopped. We never discovered where it came from. We suspect that long-term medication use caused the bleed, but he did survive, and he came home. He suffers from dementia for many, many years, and at that point he was 82. So when we come forward to 2020, when he's 83, he was having a lot of challenges and issues, and so he was getting home care every day. He was wearing a catheter. He was having trouble with balance, and so was using a walker now in the house, and was going 2 or 3 times a week to the hospital to an adult day program for people with dementia. And my mom was amazing. There's no other way to describe the amount of love and caring that went into every day coping with his dementia and with his physical health needs. Early on in the spring of 2020, my father had a stroke, and he had a green sleeve as a result of his previous hospitalization for the bleed. And he had been very clear that there was to be no resuscitation, no heroic measures. Those were his wishes. And so he went in through those emergency doors, and we weren't able to follow. And you automatically worry that with his dementia, he probably couldn't even give them his date of birth, or necessarily be able to recite the names of his loved ones when asked. And so you're left in this total vacuum of inability to advocate or be a voice for someone whose voice is compromised. He was suffering from a fair bit of paralysis as a result of the stroke. He began to have difficulty swallowing. He was apparently sitting up at that point. This is day 2, I think, of his hospitalization. They were attempting to feed him, and he choked as a result of his inability to swallow properly. And he ended up with asphyxiated pneumonia. All the way along, our only communication is really by phone with the charge nurse. It was normally the charge nurse that called, not the nurse at his bedside, not the doctor, but normally the charge nurse. And so our first question was, they could give him blood thinners to try and reduce the chances of another stroke. And my mom said, he doesn't want it. So we told them no. Then came the question of, should they treat the pneumonia? This would probably just prolong his life, but they could provide antibiotics. How did we feel about that? And each time that they called, I really felt that it was like a transactional relationship. They were really putting a lot of pressure on my mom as the next of kin to make these difficult decisions. And like many families, not just the fact that we're an Indigenous family, but I think like many families, we made decisions by consensus. We made decisions by having opportunity to talk about what we needed and what we felt was right, and to grieve and to weigh out the emotions that come with respecting my dad's wishes, because we had no idea how hard it was going to be his voice of saying no to interventions. And there wasn't space for that to happen. They never said, oh, we'll give you an hour to think about it and we'll call you back, or if you have questions, we want to think about questions you might have, you could call us back. It was always in the immediacy of needing to know. And that was really challenging. I think what else was really challenging is that they never shared any of the positives with us. So what was really hard for us as a family was wondering who was swabbing his mouth and giving him moisture, who was putting chapstick on his lips, were they arranging his pillows, was there an opportunity to play him some music to break up the monotony of the day? Did they take the time to try and talk to him even though his speech was compromised? They never shared any of those things with us as a family. And yet those were the things that weighed the heaviest on us, that we would have been able to provide that level of care, that we would have known when his pain was becoming unbearable and we could have notified them. And just feeling that his interactions of care were maybe 15 or 20 minutes long, every hour or so, depending on how busy the staff was, really weighed heavy on our hearts. And there was no effort to build relationship with us in any of our conversations that made us feel that his needs were being met on a mental, emotional, and spiritual level. And then I think the thing that still keeps my mom up at night is that he died alone. And that was the hardest thing. And I think even when they called us to tell us that he had passed, that was also transactional in nature. You know, there wasn't a lot of time spent telling us what his last moments were like. And we needed to hear those things. When all was said and done, because I've worked in healthcare for a long time, I went and called the hospital and took the time to give them some feedback about what we had experienced. And they immediately took it as a complaint. And so they wanted me to talk to their patient representative to fill out a form, you know, and that's not really what I was looking for. I was looking for someone to simply listen and to acknowledge that they could do better, and to hear what I thought my solutions could be. Not once in the 8 days that it took him to pass did they offer to take a tablet into his room and allow us to see him. It was never offered, and we never thought to ask. And so his going in to emergency was the last time that there was interaction. So thank you for allowing me to share.
Denise, thank you so much. You know, I'd like us all to give a little bit of thought to several of the things you've said, but your last comment about, you know, when you called and wanted to have a conversation with people about what had happened, that it immediately was flagged as a complaint and it gets filed under having to handle your complaint as opposed to having a conversation with you about what your family's needs were and how we could correct it. So I think it's a really important thing for us to think about in the future, and, you know, how we prepare to have those conversations and dialogue to make things better and to also to bring healing to our own lives, and that they're not automatically categorized as complaints. So thank you so much for sharing that. It's really profound lessons there for all of us. Last but not least, I want to introduce you to Robin. So Robin McGee is a psychologist by training and a determined advocate for patient safety. Robin is currently receiving treatment for recurrence of her stage 4 colorectal cancer. Much like my sister, this is a diagnosis that was significantly delayed, and it didn't have to be that way. Robin is an award-winning author. She's a speaker, the recipient of the Canadian Cancer Society's highest honor, the National Medal of Courage. Our friend Julie Drury has coined this phrase to describe the community of patient advocates, and that phrase is gently fierce. And I think of Robin as an exemplar of that term. And I say that as an honor, Robin. I've got to know Robin through Twitter. We haven't met, but we've got to know each other through Twitter. And she always is gently fierce, which I really appreciate. So Robin, with that, I'd like to turn it over to you to share your story with us, please.
Okay, well, I have an extensive patient harm story, several in fact, so I'll have to I'll summarize them as concisely as I can. So in 2008, I had active symptoms of colorectal cancer, daily rectal bleeding. I had an immediate family history of colorectal cancer in that my mother had it. And I also eventually had a positive cancer screening test. I saw 4 doctors, 3 general physicians and a general surgeon, all of whom dismissed, belittled, ignored the presentation that I had. And it took me 2 years to access diagnostic endoscopy. The standard of care should be, once you develop daily rectal bleeding, you should be investigated within 60 days. I waited not 60 days, 661 days. By the time the tumor was discovered, it was stage 4. We know that now. We didn't know it at the time. So that occasioned a whole bunch of treatments and so forth. I need to tell you that it isn't simply my opinion that my medical care was below standard. The College of Physicians and Surgeons investigated my care here in Nova Scotia, and the doctors involved were disciplined by the college. I was also able to successfully sue them in a medical malpractice action, which anybody who knows anything about that knows that it's only the most indefensible cases come to settlement with the CMPA. So in 7 years of litigation, the CMPA could not find one expert anywhere in the world able to defend the standard of care I received from those doctors. It was that bad. That really tells you how bad it was. So they were all disciplined for egregious cancer negligence, and that you can go into the weeds of each of their practices to show how it was one of those Swiss cheese perfect storm of medical error, a lot of it having to do with problems in communication. And getting back to the issue of technology, I had no access to my own medical records, so I could not see for myself the errors that kept compounding in the way these people were thinking, and the fact that they forgot. One of them got receipt of the screening test, swore up and down he'd follow up on it for me, but forgot, and therefore didn't take any action. And that was, and along with the doctor number 2 in the story was a terrible thrower and a terrible referral. Doctor 4 in the story was a terrible catcher and had terrible practices around triage. In fact, she didn't even do her triage. She had her receptionist do all her surgical triage, and had done for 20 years. So that was one of the things that was revealed in the investigation. So like outrageous practice errors. Sadly, that wasn't my only experience with medical error. I was in remission for about 7 years. When my cancer recurred, the blood marker for my cancer was going up, indicating a problem. So unfortunately, I had a CT scan, and the distracted radiologist missed a 2-centimeter tumor that was evident in my pelvis that all other viewers had been able to see right away. He, for whatever reason, missed it, wrote up a report saying, "No cancer to see here, folks," but of course there was. So 6 months later, I was able to get a scan that did reveal the malignancy, but by then it had gone from 2 centimeters to 10 centimeters. And had involved itself in multiple organs, and had unfortunately invaded the pelvic sidewall in a way that is inoperable and is invariably terminal. So what I say is doctors 1 to 4 in my first story sort of built my coffin. Doctor number 5, the distracted radiologist, really hammered the nails in my coffin, that there was no coming back from the harm done by his neglect error. So now, because I had done the medical malpractice before and the college complaint, this time what I wanted to do with the radiologist was just go through the normal patient complaint process to see because I wanted to do what I think what we've all referred to here is, how could people learn? How could we just have, what are the systemic factors that led to those errors? Is there a way that we can work towards a helpful resolution and review radiology practice to see which ways it can be improved, or there can be a better safety net for patients who fall through those kinds of cracks. And that was a real eye-opener, because it was the culture in medicine, as you may know, is the deny and defend culture, more or less, and moving to a patient-centered practice, which talks more about resolution and like we were hearing earlier about you know, I just want to give feedback so that we can improve. There, I think, as we hear, a lot of hospitals are sort of locked into very poor apology and resolution practice. And we know that patients would prefer that. Most patients want this not to happen to anyone else again. We're not in it for any other reason. We're not coming forward with our stories for other reasons. We really just want to help people avoid fates like mine. So that in essence is the story. There's a little bit more under the COVID front, but I think we'll get to that later. So that's where I'll stop for now. So my cancer recurred in the day the pandemic was announced, was the day I got a phone call saying, your cancer's back. COVID resulted in a huge long delay in treatment. It took me 3 months to access chemotherapy, 4 months to access even speaking to a surgeon. And so now yesterday I had 12 of God knows how many chemotherapy infusions. And that's my lookout for the short life I have.
Robin, can I just ask, so was the chemotherapy that you're receiving now, was the timing and ability for you to get that delayed because of COVID as well?
It was.
Right. And I want, if you wouldn't mind just taking a few minutes sharing with people. So one of the interesting things, you know, when I think about your story during the COVID era, was that you had to take to social media to get your eye surgery that you needed for the side effect for your treatment. Could you just explain that a little bit to people? Okay. You know, we all know that there's collateral damage that, you know, we refer to it as collateral damage, but that collateral damage is real people with real impacts that can affect their life so tremendously. If you wouldn't mind just taking a minute and explaining that to us, that would be really helpful.
So unfortunately, due to cancer treatments in the past, cancer-related treatments, I had developed escalating cataracts in both eyes. These aren't ordinary cataracts that take years to develop. They happen really fast. So I would lose like a whole bunch of vision every 3 weeks. So I just and so what I was told back in March is that I had 6 months before I would become legally blind, and I would be stone blind in 12 months without intervention. So I had been, prior to COVID, I was fast-tracked through all the ophthalmologists to get cataract surgery, which of course was canceled because of the pandemic. And then I knew, because my cancer had recurred, that I was going to enter a period of indefinite chemotherapy. You can't have eye surgery while you're on chemotherapy. It's just not optimal as far as your eyesight outcome. So what I ended up doing was I actually took to Twitter and I just said, there's another casualty here in COVID, not just lives, but eyesight. And I had a huge response from people, interestingly more about the eyesight than about cancer, because I think all of us can relate to how terrifying it would be to go blind, especially in a preventable blindness, even more than people can relate having cancer or experiencing cancer. So, which ironically more people will get cancer than will go blind, but in any case, I had a lot of response and a lot of Twitter advocacy. People started tweeting and emailing and Facebooking and writing letters, et cetera, to the head, the public health officer in my province and the director of the Nova Scotia Health Authority, saying, you got to make an exception for this person. And I had found a private ophthalmologist who had his own private surgery, so he wouldn't be using provincial resources. And he said, I'd love to help you, but I can't because I've been shut down by the government, so I can't do it unless they give me an exception. So after all that lobbying, months and months of lobbying and so on, and a lot of attention from media, White Coat Black Art did a story on it. And I think also the media pressure and the phone calls to the ministry saying, what are you going to do about McGee's case? That eventually brought about a positive outcome there, in the sense that I did get an email from the head of the NSHA saying, you're approved to go ahead with that private ophthalmologist. But I had to do it, it cost me $7,000, but it was my eyesight, right? So I was able to get my eyesight repaired like just before starting chemotherapy, but I would be blind today. October the 1st was the day I would be declared legally blind had I not done that. And so that's
Great.
the outcome of that
Thanks
story.
for sharing. Thanks for sharing that, Robin. So as I listen to all of your stories, I think about what we talked about earlier, that, as patients and caregivers, you've been willing to share your story with a purpose of advancing change. So, I'm wondering what you think the next 12 months look like from your vantage point. So how do you think that we can use technology and our experience with COVID to enhance the patient and caregiver experience moving forward? Let's start with Denise, but I'd love to hear from all of you about how you think we can shape this next 12 months.
Oh, that's such a big question. I think that we need to impart on the health professionals that are interacting with us through technology that they need to take the time to be relational and to get to know who we are and who the patient is that they're serving, beyond just the biomedical model, beyond just the physical care. It's really important to, in my mind, to treat the whole person. And I think as patients and as caregivers, that's the holistic piece that we bring to the puzzle. And if we're not being allowed to be present, then they need to really create the space and the time to build relations with us that will allow them to be more relational with our loved ones.
That's great. Robin, do you have any thoughts on that?
One of the things I'd like to speak about is virtual care. So during COVID, when I was finally able to access an oncologist, our very first conversation was a Zoom conversation. My spouse was able to be there. We didn't have to wear masks so he could see our faces. We could both hear what he had to say. I didn't have to travel an hour and a half to Halifax and back. So from my point of view, virtual care is something we patients have been begging for, especially cancer patients, for a long, long time. And in my view, moving to virtual and phone appointments and Zoom appointments is gospel, and that it will really, really create healthcare efficiencies going forward.
Yeah, I agree. Claire, I'm sure you have some thoughts on this as well. I'm sure you've given it lots of thought.
Yeah, firstly, I just want to second what the other presenters have said. I 100% wholeheartedly agree. I also believe that COVID has given us like an opportunity to change the entire system, like a carte blanche of sorts. And in the next 12 months is the time when we can lay some incredible groundwork for patient partnering and improving patient care. And I hope that we see more patients as decision makers in the coming year, and that we learn from our mistakes from the first wave of COVID and realize that the impacts of policies like not allowing visitors don't just impact patient dissatisfaction, they can impact somebody's life.
Yeah, that's great. Thanks, Claire. Robin, I've been thinking a little bit about your story and the similarities with my own family story about the delay in a diagnosis. And I'm wondering what recommendations would you make to policymakers or clinicians to better leverage the use of technology to enhance screening and communication that in a way that would lead to an earlier diagnosis? So, I think, how might things have been different for you with your diagnosis? If we had the technology and the acceptance of the role of digital health that we've developed during COVID?
I think one of the most important things that can allow for better improved patient safety is for patients to have access to their own records. And by that, I mean a patient portal whereby you could actually see when did that test result come in? Why was it in what medicine? You could follow up if it was your loved one. You could follow up by asking. If it's yourself, you can, I'm a diabetic, I need to take this right now. You do it in the time, not hours later when you might be in peril. So from my point of view, patient safety would be greatly enhanced. In my own story, I think I would have, had I been able to see what was going wrong in the thinking and the And the attitudes of the 4 doctors were that people under the age of 50 could not get colorectal cancer. And that was their defense when they went to court. And unfortunately, that's just nonsense. It's like saying the screening age for mammography is 50. No woman under 50 can get breast cancer. That's just silly. So anyway, incorrect thinking like that finds its way. Errors in accounting find their way. You, the patient, can say, wait a second, that's a wrong detail. That's completely wrong. They're thinking about someone else. They've got me mixed up with someone else. Patients can correct errors in their records and can fight for, wait a second, I did go to that appointment. Why wasn't there any follow-up? Says in the note here, you were supposed to do the X, Y, and Z, doctor, you didn't do it. I'm now expecting us to be able to move on that. So I guess what I want to say, for me, the patient portal and patient access to their own records is critical. I was able to access I had surgery in Toronto last year. I was able to have 2 portals at Sunnybrook and at UHN, head and shoulders above anything I've ever experienced anywhere else. And that you could have your blood work done in the hospital, 15 minutes later in the hospital, you could look it up yourself. So that is how it should be. Patients should have access to the records in real time so that we can really protect ourselves and really, and to save our healthcare providers to say, no, I'm allergic to that. I can't take that medication. Those are the kinds of things that we can keep ourselves safe and keep them safe. They don't want to create, people do not want to create errors in practice that kill their patients or harm them. So it's all to everyone's safety to have portals.
Yeah, I agree. And I often have thought about the fact that I felt like I was the only person who had the complete story of my sister's journey, because there were 5 separate stories. And me and my binders in the trunk, like we've all sound like we have, was the only complete story.
I once went to a cancer, it wasn't a cancer, it was a Patients Canada meeting, and a young man had his binder on a USB that he had around his neck at all times because he had a brain condition that sometimes he went into a coma. And they knew he couldn't be able to communicate with his doctors, but he thought, if I keep all my records on a USB around my neck, then they could look at things up. But that's what he had to do. So he had to, current case, he had to update all his records to a USB every couple of weeks. It doesn't have to be.
No, shouldn't be. Denise, one of the parts of your story that really resonates with me is the really profoundly important role of communication. Your experience, your family experienced what you described so well as transactional encounters, when what you needed was relational care. So I'd really like you to expand a little bit on that and describe what the difference it would have been to you and your family, and how you think health professionals can communicate through digital means, focusing on strength-based communications that would aid in that relationship building.
Yeah, thanks for that question, Maggie. I think that it begins with allowing us to communicate with the person that was closest to my dad, which would have been the nurse providing his daily care. The fact that we were often talking to the charge nurse and on occasion the physician was okay in terms of the medical part of the decisions, but we really needed to hear what the person with their eyes on my dad had to say. And that not just a physical report, but his mental well-being and whether he responded when he was spoken to, and whether they felt that he was being kept comfortable and his pain was being managed. All of those things that I think as caregivers we do when we're at the bedside. Quite frankly, the health professionals, it's not that they don't want to, it's that they're so busy with their patient load. And so their interactions with the patient are often small periods of time. And without a caregiver at his bedside, a family member standing there, he would have hours sometimes in between checks. And we knew that. We knew that from previous experience. And that's what weighed heaviest on us. And so they didn't stop to ask, is there a piece of music we could play for him? Is there a certain topic that he likes to talk about because of his dementia? We could have told them, you know, talk about hockey and he'll be thrilled. You know, that was his go-to for conversation. And so just none of those things happened. And then when we got closer to his going on his spirit journey, there was no ability to provide spiritual care. And that was something that was really very challenging. Now, I understand that if he had had the opportunity to transfer to a hospice, that would have been possible, but the hospice is full. And so there was no opportunity for him to receive that. And so I think about the healthcare professionals perhaps asking if there was something that they could have done to provide him with that. It would have meant a lot to all of us if they had just taken the time to provide that human side of the care. Yeah, it would have meant a lot to us.
Claire, it occurs to me that particularly because your illness has taken you through from your teens through to now, what role communication has played in your journey as well.
Yeah, communication has been a huge thing for me, especially because not only did I transition from a pediatric to an adult hospital right at the peak of all of my issues coming up to bubble, I also then went off to university in a different city, 7 hours away from where my family was. And in general, it's improving, I think, slowly as the programs that Robin was discussing improve. Some of the hospitals I have been to have EHR that connect to each other, so it's a lot easier for me to be able to share my information. So I think that's really an improvement, but overall it hasn't been fantastic.
Yeah, it's such an integral part of not just healthcare, but it puts the care in healthcare, I think, and we sometimes forget it. Claire, I'm also wondering, we've been talking about COVID, and Denise, your father's illness and passing was in the early days of COVID. You've had an experience, Claire, more recently. So I'm wondering, can you talk a bit about your experience recently and how you think it was hindered or helped by technology?
For sure. So in some sort of twisted irony, I contracted meningitis in the middle of a global pandemic. I'm sure you can imagine how thrilled my parents were when I came home from school for an MRI and spiked a fever of 40 degrees the next day, convinced that I'd brought them COVID. And I was like, I swear I didn't do anything. But it actually ended up being a really extremely positive hospital experience for me, which is really rare as somebody with complex medical history. Obviously pain and fever aside. And that was because of the programs I was just talking about. Because when I went into the emergency room, the first thing I did, I had a rash on my arm, and I put my arm up to go show the emergency physician, and he grabbed my wrist and he goes, "Oh, please be careful. I know your shoulders dislocate." And I was like, "Oh, you do you?" And then he just kept asking me questions. Like, he even knew I had my appendix out earlier this summer. And then when it came time for me to have my spinal tap done, he knew about all of my allergies, all of the special precautions he had to take with me. About the fact that I needed to have my electrolytes continuously monitored when I was there, that I needed to be on a heart monitor. And all of that was because the hospital in Ottawa and the hospital I normally go to in Hamilton run the same EMR, and they were able to communicate with each other. And I didn't really know how to react. It was like a really foreign feeling for me to be able to let my guard down in a situation like that. Because often, due to a lack of digital communication, I go into the hospital with my binder. I didn't actually have my binder with me that time, so I was really anxious going in. And even when you're really sick, you have to stay on top of like the proverbial ball. And this was the first time where I've ever experienced not having that anxiety. And it was fantastic, really.
That's great. So that's really fantastic. So I could talk with you three all day. There's so much that I want to learn from you and so much I'd like to listen to and have conversations about, but our time is getting short. So, what I'd like to do is sort of end with sort of riffing a little bit off you, Claire, and your last experience. And I'm wondering if each of you can just quickly name something that you've never seen before as a patient or caregiver that gives you hope that we'll come back better as a health system than before the pandemic. So, Robin, let's start with you.
Well, I would say two things that I've sort of referred to earlier. The increasing access to Zoom and telephone and virtual contact for patients with chronic conditions that are it's either too dangerous or too difficult for them to access care otherwise. That's not going to work for everybody. Some people need to be examined. I get that. So, but that I think we could really offload the system if we could move to more virtual. And also the patient portal piece, to the extent that that is developed, it gives us experiences like Claire just described, where we know they've read the file and they know what to be careful for. Because when you're unconscious, you can't tell them. And when you're sick, desperately sick, you can't tell them. If you have dementia, you can't tell them. So there's record access is everything.
It's everything. I agree. Denise, something that you've seen that gives you hope that we'll come back better as a health system.
Well, you might be a bit surprised by my answer, but I think about Joyce Etchikon in Quebec using her cell phone to record the racist care that she received, and the way that her braveness in doing that has launched a conversation about systemic racism across this country. And so it wasn't a positive use of technology, but it's been a use of technology that I think as patients, we need to be aware is available to us. And it's been powerful to think that perhaps it will launch some real change.
Thank you very much for bringing that up. That's a really powerful reminder of not just her story, but how that vulnerability and willingness to do that can change the world. Claire, what about you?
I think for me, it was just seeing the reduction in like an unnecessary level of bureaucratic red tape. There's so many policies that I think can really impact patients' lives, but it takes years normally. And what takes years normally during COVID time has been weeks. And I think that that's a really promising picture of innovation in our future.
That's great, thank you. So I want to thank you all so very, very much for sharing your stories. As I said at the outset, this is not an easy thing to do. And the reason that you three do it is to help others, so thank you. And now it's time for you. So it's time to ask your questions. So we're really looking forward to having a conversation and hearing what questions that the rest of you have for us. So I'm really looking forward to hearing the answers to these questions that we have from people that are attending. Thank you so much for submitting these questions. They're great. I want to start with a question from Kathy. Kathy wants to know how we as patient partners can best share our lived experience to highlight successes and new opportunities. So how do we make sure that experience sharing isn't just a checkbox in the engagement to-do list? So perhaps we can start with you on this one, Robin. Robin, you're on mute.
Forgive me, sorry, okay. Apologies. So I ought to restate your question. I think that you're wondering about.
So the question really is about how patient partners can work in a way that makes sure that experience sharing isn't just a checkbox on the engagement to-do list.
In my view, that is, there's levels of engagement in the patient engagement process. Some of that is responding to surveys, questionnaires, sort of those lower level approaches. Then there's things that get a little heavier, like being on family advisory councils at hospitals hospitals. And then there's levels even higher than that, which are going directly to government and interacting with government expert working groups and other policy formations like that. And then ultimately, there's things like patients becoming senators and members of the legislative assembly, so that we can really influence healthcare policy. So there's various levels, and it seems to me that that patients need to move up the levels in order not to simply just be a token at each level.
That's a good point. Claire, do you have any thoughts on how we can sort of move patient engagement to that level that's beyond the tick box that none of us like?
Yeah, in my opinion, might be a little bit controversial, but it was, I think, a long history of me trying to learn how to be a patient partner, especially as someone who was so young when I started. I started as a patient advisor when I was 13, so it's definitely difficult to garner any sort of respect when you have braces. But I really think that, you know, you have to be able to make your own decisions. And if you feel like you're being used as a token for an organization, that's your time to speak up and be very vocal about it. You don't have to keep that information private. It doesn't have to just be like I don't think that this is going to work for me, but that's also, if you don't believe that organization is going to change the way that they do things to make partnering with patients a priority to them, then I think that it's justified to leave and, give them the recommendations that they should use moving forward.
That's great. Thank you very much. There's also a question, Denise, that I think you're really well positioned to answer. And this is from Snehal, who wants to know, how can we work with doctors and other health providers to treat the whole person instead of individual body parts?
Thanks for that question. I think with hindsight being 2020 and having this lived experience under my belt now, I would advocate a little stronger when I was interacting with the healthcare professionals about the mental, spiritual, and emotional needs of my father. It was hard in the moment, feeling overwhelmed about making medical decisions. But I think if I was to have this opportunity again, I would really be a strong voice for making sure that their needs were being made, for asking for those soft care, I guess they would probably look at it as, needs to be met. I also would think that I might use my NGOs a little bit more. So, we had a relationship with the Alzheimer's Society. We have a relationship with Mood Disorder Society of Canada, Brain Injury Association. I could have reached out to them during my time of need and used their advocacy in that situation to push forward the agenda that my father needed to be treated as a whole person. And I don't think that during my time of hospital crisis, I thought about them as potential advocates, but I certainly have, as with hindsight, thought that they would have been a wonderful tool to act on my behalf while I was dealing with that crisis.
Yeah, that's really important, Denise. Thank you. We so often worry about being treated as a collection of body parts. So any way that we can advance that notion that we're whole people and that are made up of so many various components is really important. One of the things I think about when I think about COVID is the fact that the world changed overnight when COVID hit. And we transitioned very quickly to almost complete virtual care, at least for a while at the beginning. And as I think about this, one of the things that concerns me is access and equity. So I'm wondering who you think is slipping through the cracks currently and how we can seal those cracks. And I'm going to start with you, Robin, please.
One crack that I can think of, and this is getting to the sort of virtual and digital care aspect, is that there are people who don't have access to cell phones, iPads, laptops, or have disabilities that prevent them from interacting with that kind of media. So my concern is about those folks. As we move more to digital health and telehealth, people who don't have access to electronic or to the internet are at risk.
Yeah, that's great. Claire, I'm sure you have some thoughts on this.
Yeah. So I think that the people, often when we talk about something like this, we say that like, oh, it's the older generation who's having a hard time with digital things and, we shouldn't push people into it. And maybe it's just the fact that I'm 21 and I'm naive and maybe I'm a terrible person. But I really think that, despite people's age, you're fully able to learn these things. I taught my grandfather how to open his banking information. He loves his computer now. It's definitely not impossible. But I do agree with what Robin is saying, especially populations in rural communities or up north, they don't have the physical broadband to be able to do things like video calls. And I think that's where there needs to be an interplay between the healthcare system and, just the social system of being able to develop these things so that everyone can have the same level of connection.
Yeah, that's really important. Denise, I'm sure in your experience, you have stories of people not having access and there being inequity. And I wonder if you can just take a moment and speak to that as well.
Yeah, I actually think, Maggie, that the challenge for us is not necessarily the equitable access to the technology. It's the isolation that becomes a challenge in our care. And it's one that we faced even long before COVID. So, you hear of First Nations patients who need dialysis and there's no potable water on their community. And so they have to travel hours and hours away from home to receive that dialysis. And so they become isolated from their loved ones and their community. Mothers who are at risk during the birthing process, again, being shipped far from their family and their community to live in motels for the last month of their pregnancy in order to do something as natural and beautiful as give birth. And so I think about the isolation, and the technology gives me some hope that we could create some reduced impact of isolation in an equitable way by linking patients to their family, loved ones, and caregivers that are not able to be present wherever they may be. And I love Robin's story about being able to have, telemedicine with her spouse there and not having to have a mask. And, I think that that's a potential benefit for us going forward that would make things much more equitable than they have been for us historically.
It's interesting, Denise, one of the saddest parts of our experience with COVID has been that isolation of people and that separation from family members during an illness, a reality that our Indigenous people have lived, as you said, historically for so many years. I think when I reflect on some of the stories I hear during COVID, there is that emptiness that comes when people are isolated. I think about the stories in long-term care and people dying alone. And I wonder how each of you think digital communications might be able to bridge the distance that COVID has brought between patients and families instead of making the distance greater. Claire, what are your thoughts on that?
Even in the situation that Denise was describing, there's so many ways that you can have technology in a patient's life, even if their family can't be there. Like when she referenced bringing a tablet into the room so that her family could see her father and speak to him and, provide some level of personal care. I don't see why that wasn't immediately offered. I think that there's so many opportunities for things like that to happen. And I remember when I was quite young, my first hospital admission, I was added to this social media group for like young teens in Canada in the hospital. And I remember being super shocked that A, they had this platform, but B, but just how great it was as a community that you could connect with other people And I think that we could do something like that for all patients in Ontario or Canada as a whole.
Yeah, that's well said, Claire. Thanks. There was another question from Phyllis. Phyllis, really nice to see you, so to speak. And that's, how can the health system better provide transitions in care and better communication between healthcare professionals during handoff and patients and caregivers throughout the entire care process? At its core, the question is really asking, how do we prevent people from being lost and sometimes forgotten in the system? Robin, maybe I'll start with you with this question, please.
I work in education, in which there are often transitions. So kids transition from elementary to middle school to high school. And the responsible thing to do there is to have sort of a multidisciplinary meeting. I think you were saying about the silos your sister encountered, and I certainly have encountered in my time, that if we could have multidisciplinary meetings in or around the transition point. So for example, when Claire was leaving the pediatric system and going into the adult system, had there been some kind of, who is her point person on the adult side? That person should meet with everybody attached to her previous care to hear, okay, we got to know this, 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 and this. So to me, it's all about communication, and it's about timely communication at the point of transition. Education can do it. There's no reason healthcare can't.
Claire, I'm sure you have thoughts on this. You've obviously been in the system during transitions, and do you have any thoughts on how we can change this?
Of course. I definitely think that technology is the solution again here. I hate to repeat the same sentence over and over. And when I say technology, I don't just mean the development of a universal platform, as great as that is. But I mean having access in real time and having the ability to upload your own information into this electronic record. This ensures that everybody involved is informed and prevents careless mistakes.
That's great, thank you. One of the things I've been thinking a lot about is as the move to virtual care is happening at such a rapid pace, it's really necessary that patients and caregivers be at decision-making tables as co-designers of that care. So I want to take us up to a bit of a higher level discussion, a bit of a strategy discussion. So one of my observations during COVID would be that in the name of expedience, patients and caregivers are not as involved in the development of programs and policies as they should be. What comes to my mind immediately are the blanket no visitor bans earlier on in the COVID pandemic. And they'd be an example of where caregivers and patients were shut out of the development of policy. So I see more than ever with this, the need to move from a paternalistic to a participatory model of care. And I'm wondering how each of you think technology can be used to support hearing the voices of patients that care is designed for and those who care for them. And Denise, maybe I'll start with you on this question.
Sure. So I'll say that I've worked in healthcare for a long time, besides being a patient caregiver with my parents. And one time that we see the system really come together in a multidisciplinary integrated way is when they're planning discharge. They are very effective at pulling together a multidisciplinary team, your nurse, your respiratory therapist, your social worker, everyone, the patients, the family, everyone is present because they are motivated to have you move and transition from hospital care to home. And I think that if they took that same approach at the time of admission, then we would start to create an equitable and holistic way of treating the patient from the time they arrive through the door. And so I'd like to see what they do sort of at the end of stay for discharge, moved upstream, and create that kind of multidisciplinary and integrated discussion and support at the beginning, at the time of admission.
Yeah. Robin, I wonder if you have any thoughts on this.
What I'd like to do, your question was about technology and in sort of improving care, I want to draw attention to the document that AMS has attached to our session for today, which is called Empowering Patients and Caregivers. And it runs through a series of technologies, talks about wearable technologies like heart monitors, certain kinds of apps, chat boxes, the use of EMRs like we've been discussing, the use of sort of alert systems to communicate with the patient when their data suggests they're in trouble. All of those technologies are described in the AMS document. I'm going to invite the interested to go and check that out because it really does a great job of looking at that technology, outlining where the benefits might be, where the downfalls might be, and approaches to solution, and inviting, of course, commentary on that. So that's what I want to do. I want to draw attention to that document because in my view, it really does show how technology can improve patient safety, quality of care, quality of communication, all of the things that we've highlighted today as important.
That's great. Thank you. You know, one of the things I've been thinking about is, part of the focus of the conference is around compassion in virtual care. And, we've talked today about compassion and care and communication, the importance of empathy. Yet I think we still tend to see virtual care as dispassionate and disconnected. So while we sometimes see virtual care and compassion on opposite ends of a continuum, we need to bring them together. So I'm wondering if you see ways that we can foster compassion using virtual means. And what does compassion look like when using virtual care? Denise, maybe we'll start with you for this question.
Well, I really like the idea of compassion being bringing the technology to the bedside of our loved ones when we're isolated and disconnected. I happen to watch TV. I'm a TV junkie, and I watched The Good Doctor last night. And there was a scene where this wife is constantly on the cell phone at her husband's bedside, and she's, shouting out to the doctors information she thinks they need, and she's giving words of encouragement to her loved one. And I cried through the whole thing because I thought, that's what it's all about. And I can't tell you what sense of peace I would have had if just one person in the hospital with my father had thought to bring us virtually to his bedside, and if we could have drummed him out on his spirit journey and allowed his spirit to soar the way it was meant to. That would have been everything for his end of life care, and it would have been complete and total peace for us as a family. And that it doesn't take a lot of technology, Facebook Messenger, FaceTime. It's just that the system doesn't carve out the time and the space to make it possible.
Denise, it's such an important reminder of the integral role of compassion, and that it really is at the heart of healthcare. Healthcare is not a series of interventions and a series of things that we do to people. Healthcare is about heart and about relationship. And those things cannot be understated. I think a little bit about our experience when my sister was in the ICU for so long. And the things that she talks about afterwards that mattered to her were the nurse who came and wet her lips, was me being by her side and being able to recognize that she was uncomfortable and needed her pillow flipped. Did those things change the outcome of her disease? No. But did they make that journey that she was on have some, not just memories, but have some value and see her as a valued whole person? Yes, they did. And they did so because of compassion. So I really appreciate you sharing the story about your father and your family. I know how difficult it is, and I know how much pain is involved in it. I'd like us to also think a little bit about kind of how technology plays a role, not just in providing care, but in providing quality of life. So, we're transitioning and thinking about compassion. What's the role of virtual care in ensuring people, for example, in long-term care during COVID, have a quality of life that really matters and that honors them as people? Claire, maybe I'll start with you and see what you have to say about this.
Yeah, thank you, Maggie. I think that in today's day and age, the role that this plays is like completely insane to me. There's so much that we can do with technology now. I mean, even at my school, we have a program where you get to FaceTime with the seniors in an old age home who can't visit with their families, or maybe their families, might have passed on. And you can develop relationships with them like you've never been able to before. You don't need to be in the same room with somebody. And I think that's fantastic. And then also as a patient, technology for me, in terms of quality of life, having my results to things easily accessible at the tip of my fingers, that gives me a quality of life. That means there have been multiple times where I've been able to go into a hospital, have my blood work done, and because I get my results the second they're done, I don't need to wait in the emergency department. I've been able to go home 13, 14 hours earlier than I would have because I'm able to monitor those things myself. And that gives me the chance to do the things that I love to do, which is definitely not being in an emergency department.
Right. Well, and when I think about that, I also think about the reduction in anxiety that comes with having all of your information. So, not waiting over a weekend to get lab results, or not sitting at home waiting for your doctor to call to get lab results. Robin, I know you've got some thoughts on this, so I'd like to invite you to share them as well, please.
I just need to echo what Claire said about, and what you said, Maggie, and we all said on Twitter about how important it is that patients have real-time access to the immediate information they have. And I know there's a debate where they're saying, oh no, we can't let radiology results or any other news come to the patient because it has to go to the doctor first. And I guess I think, who decided for me that I would rather hear bad news in a doctor's office than at home in the bosom of my family? Who decided that that was how I need to hear bad news? I'm a cancer patient. I've had bad news for 10 years now. So I think that there's still an element of paternalism in how medical records are shared. And I feel that needs to be addressed in the medical culture to just respect that there are people who need this. I remember once a radiologist said, I don't think we should ever let patients have access to their data, radiological data, because they're too unenlightened to understand it. And a woman wrote to him saying, which I thought was very powerful. She said, we don't say that pedestrians cannot access a walking bridge, because some pedestrians jump. The bridge that the portal gives to me, to my safe healthcare, is as important a bridge to me as any walking bridge. So we will develop safety nets for patients who can't handle their digital information, but give us credit. The majority of us can and want to work with our own health information in a responsible way.
That's a really powerful analogy. I haven't heard that before. It's great. So, we've talked a lot about the era of COVID and our experiences. So I'm wanting to look out a little bit. And I'm wondering what each of you sees as the greatest trends and challenges that patients and caregivers will face in the coming, say, 3 to 5 years with respect to virtual care. Denise, let's start with you.
I think the biggest challenge we're going to have, Maggie, is sustaining our energy. This is not going to be a quick fix, and we need to be a voice, advocate, and we need to be in it for the long haul. So I think sustaining our energy and enthusiasm will be our biggest challenge.
And Claire, what about you?
I completely agree with what Denise said. I think that that's very well put. I think on top of having to sustain this energy that we have, you know, there's also this sort of magical glimmer of hope that I have, because everything has been turned on its head. And, you know, if we can weasel our way into the woodworks now and finally climb up the ranks and actually get to make a difference as patient partners, I think that, you know, we're going to create a whole new world.
Great. Robin.
I just want to echo what my counterparts are saying here today, that this is, they've said it.
I love Claire's notion of creating a whole new world. It's that's a great note, Claire, to sort of end our questions. You know, I think we are at the precipice of a brave new world and a great new world.
Maybe don't want to say brave new world.
Yeah, well, it's true. True. So I can't believe that our 90 minutes has flown by like this. So I hope that you'll be as engaged in the upcoming sessions of the conference as you have been this morning. I know this afternoon a terrific panel is going to delve into the question, is technology truly a solution? Tomorrow morning, there's going to be yet another stellar panel that explores digital health. How do we get there together? And then closing the conference tomorrow afternoon is a session that really speaks to what matters to all of us. So how are we going to make it happen? We hope that our conversation this morning has challenged you, answered your questions, and given you food for thought. I like to end on a note of gratitude. So I would like to start by telling you how grateful I am for each of you as presenters today. Claire, I want to thank you for your courage and your optimism as you continue to face such complex health challenges. Your lived experience, along with your smarts, will make you a terrific doctor. Denise, I want to thank you for sharing about your father's spirit journey and about the journey that your family has been on as you've tried to reconcile the reality that you faced during COVID with what really mattered to your family. And Robin, I want to thank you for being so open and vulnerable about not only your horribly delayed diagnosis, but about the barriers that you faced as the cancer has progressed. You've used your voice to speak truth to power about patient safety across Canada, and you've done it in a way that I believe is leading to important change. And to all of you that are attending the conference with us today, I want to thank you for joining us. I want to thank you for your engagement. Your questions were great, and although we didn't get to them all, we're going to try and answer them as many as possible offline. To the organizers of Hearing Your Voice, thank you for your vision and recognition of the importance of patient and caregiver voices. Thank you for really listening to our stories. To each one of you, I want you to be encouraged today and know that it's through our stories that we can communicate the importance of ensuring healthcare is humane, that we will insist on the prioritization of compassion. Patient stories, the importance of lived experience is not a fad. There's a growing recognition of the key role of patient and caregiver voices at the table as vital decision makers. I really believe that we're starting a movement in this country that there's no going back from. I want you to know that your willingness to share makes a difference every day. I want you to know that your efforts to affect change in healthcare matters. I want you to know that there is tremendous power in your lived experience. And with that, I want to thank you today, and I hope that you enjoy the rest of the conference.